Hello, friends. Give a overview on this very important and simple topic, which I'm sure all intensivists will be dealing with this day in and day out, especially now in the flu season. So the topic is simple approach and management of community-acquired pneumonia. And last few slides, I'll touch on non-resolving pneumonia. So very often we do encounter situation where pneumonia not necessarily may be resolving. So we'll talk about non-resolving pneumonia as well. So I gave this talk in one of the Bangalore brick meet. So wish to get the greetings from these two hospitals I represent, Manipal Hospital Yelahanka and Manipal Hospital Yeshwanthpur. So the topics that I would cover is the definition. So how do we say that patient has pneumonia, epidemiology, and what is its burden in India? So I've looked into the references in India to try and ascertain what is the burden of pneumonia in India. So this is the most important aspect for all intensivists. There are at least 9 risk stratification tools. I'm sure most of you would have heard only of CURB 65, but there are 9 sort of tools that are available which stratify the risk of a patient coming with pneumonia. I will talk a bit on diagnostic workup and microbiology and antibiotic treatment as per the standard guidelines globally. And then we look into non-resolving pneumonia, the definition. When do we say it's non-resolving pneumonia? I think that is something every intensivist should know, and the causes. So what are the causes for non-resolving pneumonia? Diagnostic workup, management approach, and key takeaways. So these are the topics that we would cover in maybe next 20 to 25 minutes. So community-acquired pneumonia, as the name it stands, was first coined by this gentleman, William Osler, in 1892. So this was a stamp issued in 1969 by Canada to commemorate 50th death anniversary of Sir William Osler. And if you look into the mortality, so especially community-acquired pneumonia, when they become sick and come to ICU needing vasopressors, so the mortality sits around 50%, friends. So it means it is not a Mickey Mouse condition. It is a quite disastrous and sinister condition if it not identified and treated very early on. And more so when they come to ICU, they all qualify as sick community-acquired pneumonia. And there is a compelling evidence which suggests that there can be underestimation of the severity many a times. At the same time, there can be overestimation of severity. So that is where we need to focus on risk stratification tools to exactly identify which are the patients who are sick and whose mortality remains high. And this underestimation of severity has led to inappropriate discharges from the hospital. And overestimation of severity has led to another diabolical endpoint of unnecessary admissions to hospitals. So this is very important epidemiologically. So that's why we need to have some clinical acumen to ascertain which sort of a risk category a pneumonia belongs to so that we can calibrate the treatment more effectively. So now coming to the juice of the matter. So definition, epidemiology, and burden. So definition is very simple. How do we define community? Someone coming from the community. You see anything now, you have to integrate these 4 parameters, which I tell all my intensive care friends. It has to be clinical, lab, and imaging. In pneumonia, 2024 to 25 guidelines, because this question was asked in DRNB this time, what is the 2025 guidelines for treatment of community? In 2024-25 guidelines, ultrasound or focus also has been incorporated as a tool to establish or confirm the diagnosis of community-acquired pneumonia or pneumonia for that matter. So when we talk about clinical, you look at temperature, cough, shortness of breath. So these are the symptomology, and signs you would look for bronchial breath sounds, so on and so forth. And when you look into the lab, you would look into the inflammatory markers, leukocytosis, raised CRP, raised procalcitonin, so on and so forth. Imaging, chest X-ray is the first sort of a imaging choice. So you would see a consolidation of some nature or infiltrates which point out or ground glassing, opacity, so on and so forth. And when you look into ultrasound, obviously you look into the shred sign or you look into sort of a B pattern, so B lines, so on and so forth. So these are some of the clinical features, and there should not be any other alternative explanations for these sort of a features so which qualifies as someone having pneumonia. So definition basically encompasses the clinical, lab, imaging, and focus also can be incorporated. And you can list out all the symptoms that you could expect. You could list out all the lab parameters that tends to be deranged and the radiological sort of an imaging. So now let's look into the epidemiology. So most data comes from US. In US, there are 1 to 4 million emergency visits per year due to pneumonia, out of which 740,000 admissions happen into the hospital per year. So this is the burden of community acquired pneumonia. 7,40,000 admissions happen in year with 41,000 deaths per year. So this is the recorded US data. So I tried to look into the Indian data. It's a little sketchy, but we have some references to. In India, the occurrence rate is 5 to 11 per 1,000 population group. So if you take 1,000, there can be 5 to 11 which can have community acquired pneumonia. And this is the reference we have in 2024. So 19% of these pneumonias which get admitted to hospital tend to have severe community acquired pneumonia. This is the data we have from India. And in India, case fatality rate when they get admitted to hospital is around 14 to 30%. And if it is a SCAP, is severe community acquired pneumonia, it's 47. So if you recall the slide I showed you first, the William Osler slide, in community acquired pneumonia needing vasopressors, mortality is up to 50%. And so this alludes to the data. In severe community, even in India, the mortality has been 47%. So this is the data we have from India. And there are certain population which are at high risk of developing community acquired pneumonia, typically the elderly population or someone with an underlying chronic lung disease. If someone has a COPD, someone has an asthma, someone has a bronchiectasis, someone has a lung malignancy, they are at a higher risk of developing pneumonia, or someone who is immunocompromised due to uncontrolled diabetes or due to autoimmune diseases or due to progressive end-stage chronic kidney disease, progressive liver disease, or progressive sort of an underlying malignancy, so on and so forth. All of them are at a higher risk of developing community-acquired pneumonia. So in 1997, so the first sort of a scoring tool was defined, so-called Pneumonia Severity Index, which was done in around 40,000 patients, which stratified the severity of pneumonia into 5 risk classes based on the risk of death of the patient when they develop community-acquired pneumonia within 30 days. And these are the classes they had. So for ICU, the relevance is class 4 and class 5. So in class 4, the risk of death within 30 days was 4 to 10%. And class 5, where the score was more than 130, the risk of death within 30 days was 27% in ICU. So this was the risk stratification that first came in 1997. And when they looked at the ROC, receiver operation characteristics and area under curve for 30-day mortality, the predictive ability was good enough at 0.7 to 0.89. But pneumonia severity index predictive ability for ICU admission had a much larger range, as it is AUC was 0.56 to 0.86. So there was a wide sort of a range for that. So that was, and ATS and IDSA sort of a criteria did recommend at that point of time pneumonia severity index as a tool to stratify. But there were certain limitations of pneumonia severity index because in elderly it overestimated the severity, in younger patients it underestimated the severity, and it did not capture the important risk factors like diabetes or COPD. So now the question is, what are the components of pneumonia severity index? Components are, one would imagine intuitively, these were, so it took age, it took the gender, it took all the comorbidities. But if you see in these comorbidities, it did not take diabetes and COPD, which is very important. Those were the limitations. And physical science, it took confusion, respiratory rate, blood pressure, temperature taken, and lab, it took all these other parameters. So, and this was scored, and the numbers you see are the scoring. If it was more than 150, it was this PSI of 5. And less than that, it was PSA of 4, and that had a correlation with mortality. So that was the earliest risk stratification. Then subsequently, a lot of risk stratification tools have come. I'm sure the most popular is Curve 65. So if you ask me the scoring tools, there are 9 scoring tools that have come. So these are the ones. So there is IDSA and ATS criteria. Then the UK, every country has come out with their scoring tools. Curve 65 came from UK and SOAR came from UK. Australasia came with Smart Corp and Corb. Spanish people came with SCAP criteria and PIRO-CAP criteria, and Japanese came with ADROP. So these are all the different criteria. So I don't expect all of our trainees to know everything, but we'll just talk about 2 to 3 criteria because I have to cover a lot of other aspects of pneumonia. There's a separate video where I've spoken about all these scores. So the common ones, the more popular ones is CURB 65, so which basically came from British Thoracic Society. Again, this was done in a cohort of these patients. So it's very simple, just pictorially I have put it. So basically CURB is C stands for confusion. This is an acronym. C stands for confusion, U stands for urea, urea more than 7 millimole per liter. R stands for respiratory rate more than 20. 65 is age, P is blood pressure less than. And you saw someone hypotensive with pneumonia, needing vasopressors, the risk of death comes up to 50%. So CURB 65 is very simple. It's an acronym, and this is the one which we tend to commonly use. And what is the sensitivity and specificity of the curve? So these are the scoring. For everything, there is a score of 1. So confusion gets 1, high urea gets 1, respiratory rate more than 20, 30 gets 1, and systolic blood pressure less than gets 1, and age more than 65 gets 1. And limitations, and there are limitations of curve because it relies on the lab parameters, and elderly patients, it underestimates the risk. That is another sort of a limitations. So to circumvent the need for lab parameters and to rely only on clinical, they have introduced CRB 65, where they have removed urea because you don't have a lab. And if you see the risk stratification, if your CURB 65 score is 3 to 5, 30-day mortality is around 22%. So this is something you can just remember, that higher the score, higher is the risk of mortality. So here they have looked at comparison. This was a meta-analysis, looked at the comparison of pneumonia severity index, which first came, and the CURB 65. If you see, pneumonia severity index had a sensitivity of 0.9 and specificity was very low. So CURB 65 had low sensitivity but had a better specificity. And the reason for this course is to try and identify and stratify whether they belong to severe community acquired pneumonia or they belong to high risk patients. And because of CURB 65 having low sensitivity, many a times incorrect diagnosis, and some patients are treated as non-severe. So that is some of the limitations of CURB. And it is shown, if you incorrectly diagnose and treat as non-severe, if there is delay in ICU admission, it was shown to be associated with the risk of short-term mortality. This is very important for intensivists. If you do not treat severe pneumonia in ICU by good risk stratification, there is a direct correlation with the short-term mortality, which was shown in this particular study. So we finished about PSI, pneumonia severity index. We spoke about CURB 65. Then let's look into IDSA ATS criteria, which is Infectious Disease Society, American Thoracic Society. This is also very pertinent to ICU patients, which has major and minor criteria. Remember the picture I showed in CURB 65? That picture along with someone who is ventilated and needing vasopressors. So someone who is intubated and mechanically ventilated automatically falls under major criteria. Or someone needing vasopressors fall under major criteria. Minor is, remember that picture, confusion, respiratory rate more than 20, blood pressure less than this one. So major criteria is intubated, ventilated, and vasopressors. Minor criteria is confusion, fever, respiratory rate more than 30, PF ratio less than 250, blood pressure. These things remain common in most criteria. All the 9 criteria, confusion remains, fever, respiratory rate more than 30, PF ratio less than 250, blood pressure less than. And these are additions. Blood urea more than 20, leukopenia and thrombocytopenia are the minor criteria, or multilobar lung involvement on the chest X-ray is another criteria they have. And they have shown by applying this, it had a low sensitivity if you apply only minor criteria, but it had a high specificity of 91.7% in identifying high-risk patients. So any patient with one major criteria, someone needing vasopressors, there's no business to be outside ICU. They need to be in ICU. or 3 minor. If they have any 3 minor, that is the indicator for having ICU admission. And it was shown that IDSA ATS criteria was better than CURB 65. For all intensive care friends, either you can apply CURB 65 or if you are very specific to ICU, IDSA ATS criteria seems to be better than CURB for determining ICU prognostication. And as you see, they have looked at the sensitivity of IDSA and ATS, 88.6%, and 30-day mortality area under receiver operating characteristic was 0.63 to 0.67, which was not a great in predicting 30-day mortality. So if you remember those, so there is a separate video I have done where I've spoken about all the 9 scoring tools. I've spoken about Smart Corp, I've spoken about Corp, I've spoken about PIRO criteria, SCAP criteria, so on and so forth. But here I restricted to mainly CURB 65 and IDSA ATS, which is more pertinent and you can remember and recall. So now let us look into microbiology and pathogen detection in community acquired pneumonia. So it is shown that pathogen is identified only in 38% of hospitalized patients. 40% of community acquired pneumonia is caused by viruses, and 15% of them are caused by strep pneumonia. So obviously for all intensive care friends, we ask in exam, what are the common organisms causing CAP? And many of them tend to fumble even with this. So I'll show you what the Indian data show. This is the reference which is published in Indian Journal of Medical Research in 2020. Strep pneumonia constituted commonest cause of community acquired pneumonia at 19%. Mycoplasma pneumonia was the second, which caused 15%. Then 10% was caused by Kleb pneumonia as from this particular study, and 7% was caused by Legionella. So the others which causes common community acquired is H. influenza, Staph aureus, and Chlamydia. So this is how all these organisms looks, just for you to recall and remember. So this is the sort of epidemiology in India, commonest organisms that causes community acquired pneumonia. So what are the diagnostic approach to community acquired pneumonia? The first choice is always chest X-ray. So do a chest X-ray, look for any infiltrates or lobar consolidation, so on and so forth. And point of care ultrasound has been incorporated in the recent guidelines as a tool that you can utilize to look for spread sign, to look for B patterns, so on and so forth, to try and recognize the pneumonia pattern. And of course, you have to do blood cultures, you have to do sputum cultures. Then you can look at urinary antigen for streptococcal antigen or Legionella antigen, so on and so forth, and multiplex PCR. So these are the diagnostic tools. I'm sure every listener listening to this would be doing this test. You immediately ask for BioFire or multiplex PCR, and we do send sputum cultures, and we do send blood cultures, and urinary antigen for Legionella or streptococcus is as a point of care we tend to do. So these are the typical tests that we do. So now let's look into biomarkers, whether biomarkers have any role. So biomarkers have an ability to predict disease severity and outcome, and biomarkers help us for rapidly prognosticating, easily available, and it's at a low cost. So let's look into different biomarkers that are tested to prognosticate pneumonia. So they have looked at CRP. So Chalmers et al. Looked into 570 patients, and they have looked if CRP is less than 100 milligrams per deciliter, it excludes SCAP, which is severe community acquired pneumonia. And it has shown if someone has low CRP, these are the patients who are at a low risk of 30-day mortality, low risk of mechanical ventilation, and low risk of needing vasopressors. And accuracy of CRP was similar to CURB 65 and pneumonia severity index. But data is inconsistent. Then let's look at procalcitonin. So procalcitonin, unfortunately, did not show a good prognostic ability because small changes in procalcitonin was not helpful in delineating between survivors and non-survivors. And there was an overlap. So there was a CAPNet study which came from Germany, which said procalcitonin was a good predictor of severity and clinical outcome. And there was another study from the Swiss group, like a Muller et al., where it said procalcitonin had a good correlation like CRP with pneumonia severity index and CURB 65. Then there was a GenMI study where it showed if procalcitonin is less than 0.1 nanograms, Then it was associated with low 30-day and 90-day mortality, reduced ICU and hospital length of stay, reduced ICU. So like CRP less than 100 or procalcitonin less than 0.1, you can remember as the patients who are safer and who would not possibly die and who would not need ICU. So this is the evidence we have about CRP and procalcitonin. What about D-dimer? So D-dimer, this was a study from Spanish group called Pirol Ribellas, where they showed if D-dimer is more than 2000 nanograms per ml in community acquired pneumonia, it had a correlation with significantly high mortality. And Chalmers et al. Study showed if D-dimer is less than 500 nanograms, the likelihood of 30-day mortality is zero. And the likelihood of needing mechanical ventilation and vasopressor also is close to zero, which means CRP less than 100, Procal less than 0.1, and D-dimer less than 500 are all safe indicators or signals towards good outcome in these patients. That is what you can remember. So the conclusions they made from D-dimer is at admission, D-dimer can predict low risk of death and major morbidity. And even they looked at cortisol. Qualtitz et al. Has showed that cortisol can be an independent predictor of mortality and it can be a predictor of hospital length of stay with a good AROC at 0.81 by this Japanese study. And they looked at other biomarkers like copeptin. So Capnet's study showed copeptin is a good predictor of 28-day short-term mortality and 180-day long-term mortality. These are newer biomarkers there, but I think for practical purpose, CRP, procalcitonin, and D-dimer are something which we commonly use. We can keep this in mind. Copeptin, these are all for research purposes, and it showed the copeptin had a better performance than KERP65, better performance than CRP and procalcitonin. Then they looked at proadrenomedulin. So proadrenomedulin also had a good correlation with pneumonia severity index. This was a study from the Swiss group where they looked at 1,653 patients where they combined proadrenomedulin along with the pneumonia severity index, and they found that area under receiver operating characteristic improved when they added proadrenomedulin. The AR ROC improved from 0.69 to 0.75, and it increased and it heightened the predictive ability of KERP65. So basically it says you add a biomarker to your pneumonia severity indices like KERP65 or IDSA ATS criteria, you add a biomarker, it enhances, it heightens its predictive ability is what was shown in this study. It had a good discriminatory. There is something called mid-range pro-atrial natriuretic peptide. This is another biomarker. They found it had a good correlation with pneumonia severity index and KERP65, and it had a good prognostic performance in predicting short-term and long-term mortality. And the mid-range pro-ANP, when they compared with procalcitonin in this Spanish study, AROC appeared to be better than procalcitonin. These are newer biomarkers. So you can just in exam write about these newer biomarkers, proadrenomedulin, mid-range pro-ANP, and copeptin. So these are some of the things you can write. Then there is BNP, which we do. Beta natriuretic peptide also had a predictive accuracy and it had an independent predictor of death in this study. When BNP is high, I think this is something which trainees should do a study because CAP having high BNP was associated with non-survivors. So very often, friends, these days, any community acquired pneumonia, we see BNP being high, we see a lot of B lines and we do diurise them. So this is a common feature. Maybe we should do more of our own studies to try and see all this community acquired pneumonia tend to have more of fluid component also, possibly because of the stress in the heart. And this is what these other studies have shown that increased BNP was associated with the non-survivors. And when BNP was added to the pneumonia severity index, prognostic accuracy, as you saw, significantly improved, and that was statistically significant. So there are other severity tools. So Feldman et al. Looked at platelets at admission as a prognostic marker. So someone with a low platelets, pneumonia with thrombocytopenia, also is suggestive of SCAP, severe community acquired pneumonia. So when a pneumonia comes with low platelets, you should be more worried. They are at a higher risk. And we have seen in our patients, pneumonia coming with low platelets, they tend to have more sort of a tumultuous ICU course. So platelets being low was associated with higher mortality. And this was a study which was done, which showed low platelets was associated with more non-survivors, and that was statistically significant. These are simple studies which all our DRNB trainees should embark on doing. Look at low platelets as a prognostic marker, and look at BNP and its correlation with severity. So these are all the studies that we should be doing and publishing. And this was another study which showed the opposite, where someone who have a very high platelets of more than 4 lakhs, that was also associated with increase in 30-day mortality and increase. So low platelets is bad. Thrombocytosis more than 4 lakhs also was associated with 30-day mortality and length of. So these are all the biomarkers, very interesting for our DRNB students to embark on doing some projects on this. Then this is one interesting thing. They looked at uh, the bacterial DNA load. So, and this has shown to have a strong predictor of risk of death. Obviously, bacterial DNA, which is measured in RT-PCR, so that has showed a good predictor of risk of death and shock. And this DNA load could be used to monitor the response to the treatment and even to reduce the duration of antibiotics. So basically, DNA is you look at the number of DNA copies in multiplex PCR and try to screen it and see if there is a reduction in these DNA copies, which is a response to the treatment. So conclusion is there's no single biomarker which is a gold standard for CAP assessment, but these all can be used as an adjunctive tools to complement your clinical scores like CURB 65, ATS, IDSA criteria, or SCAP criteria, so on and so forth. So it can be added as an adjunct to your clinical tools. So there are other newer biomarkers for all the clever ones called the RAGE, receptor for advanced glycation end products, or high mobility box group box protein, and certain sort of antibody expression from these cells. So these are some of the newer sort of a biomarkers you can think of. So that's about, so we spoke about the risk stratification, we spoke about epidemiology, we spoke about the diagnostic armamentarium. So what about the treatment? Treatment is, so I'll only confine to ICU treatment of pneumonia. When I say ICU treatment, they all qualify as severe pneumonia, which is SCAP. So treatment is very simple. So you have to use either ceftriaxone 2 grams per day with macrolides, azithromycin, or cefotaxime with azithromycin. So you have to add MRSA coverage if the patient is at the risk factors for MRSA. What are the risk factors for MRSA? Someone with a previous MRSA, someone who has been hospitalized, or someone who is an IV drug user, they are at a risk for MRSA, where you have to add vancomycin or linezolid. If someone is at a risk for pseudomonas, so what are the risk factors for pseudomonas? Someone with bronchiectasis, someone with a chronic underlying lung disease, or someone who has received previous antibiotics, they are at a risk for pseudomonas, or someone comes from another hospital, you can add piperacillin tazobactam or cefepime or meropenem or carbapenem. So these are some of the suggested drugs for community-acquired pneumonia. So now we'll talk about this interesting aspect, which is important for trainees, non-resolving pneumonia. When do we call non-resolving pneumonia? Non-resolving pneumonia, we call it when there is no clinical improvement, when there is no improvement in the lab parameters, when there is no improvement in the radiological sort of a signs. 10 to 15% of hospitalized patients with pneumonia tend to have this non-resolving pneumonia. What are the causes? Causes is where you are given inappropriate antibiotic, or whether you are dealing with resistant organisms where patient had been at risk for MRSA due to previous hospitalization or due to the underlying chronic lung disease, so on and so forth, who has resistant organisms, MRSA, ESBL, or Pseudomonas, or they have untreated causes of community like fungus or mycobacterium. They can be having TB and you are treating, or they have atypical organisms which you are not covering, or someone who has persistent viremia. So it can be viral infection which has not settled, or pneumonia which has complicated into empyema or abscess. So they are the ones who do not respond, or where you call it as a non-resolving pneumonia. What are the causes of non-resolving pneumonia? It could be some of the differential causes for non-resolving is there are other possible overriding or overlapping features like aspiration, pulmonary edema. These are differential diagnoses: venous thromboembolic disease, pulmonary hemorrhage, or they may have underlying malignancy, some sort of an inflammatory process leading to ARDS, some sort of an underlying occult malignancy. and other organisms which are not being covered, and under exacerbation of the underlying conditions. So these are the typical differentials or drug-induced pneumonitis, so on and so forth. So these are some of the differentials for non-resolving pneumonia. So what is a diagnostic workup for non-resolving pneumonia? So this is important for all our trainees. Step one is reassess the basics. Review the diagnosis. Review the diagnosis and see whether it's pneumonia at all, and look into whether the antibiotic coverage has been appropriate, whether there has been adherence to the treatment, and whether there has been any drug reaction, and review whether patient is immunochallenged. Many a times we would be treating, then suddenly we realize that patient has had some sort of a immunochallenged conditions, or someone who may be HIV positive, which we may not be aware, and he may be having PCP. We have seen it in our own ICU where we treat a scab, then we see it's not improving, then we get a history, then we do HIV, it comes positive, or they may have underlying malignancy, or many a times they'll have underlying. So we had recently a patient who had underlying psoriasis, was on methotrexate, which were not aware, so on and so forth. So find out whether they were immunosuppressed, whether there was any other comorbids which was not documented. Step two is you have to repeat imaging. So X-ray may not be enough. You may have to subject the patient to CT. If it is a non-resolving pneumonia, you may have to subject to the CT scan. Step three is you have to escalate microbiology. You may have to do the repeat cultures. You may have to do bronchoscopy with BAL cultures. Then you will have to do advanced diagnostics like multiplex PCR, so on and so forth. And then you have to broaden your antimicrobial coverage, add MRSA cover if it's not covered with vancomycin linezolid, or you have to add Pseudomonas treatment if there is a pointers or signals pointing out to this. Sorry, Pseudomonas is not vanc linezolid. I think I've just cut pasted that. Pseudomonas, you have to add Pseudomonal cover like fourth generation cephalosporins, piperacillin tizobactam, carbapenems, or cefepime, or consider antifungals if there is patients are at risk for antifungal fungal disease, and if there are risk factors pointing out to fungal disease. And if there are complications like empyema, you have to drain by putting underwater seal drain. If it is a lung abscess, you may have to put a pigtail. So this is the approach to non-resolving. So please remember 10 to 15% can fall into one of these categories of non-resolving pneumonia. And maybe at this point of time, you may have to involve ID specialist. So that's about it, folks. So it's a simple topic, but very important to have a clarity. So trainees should focus more on risk stratification, and maybe should focus on having an awareness of biomarkers and having a little clarity on when we call it as non-resolving pneumonia, and the means and ways to approach it. So request you all to submit your valuable work to Journal of Acute Care. So of course you can visit my website to rehear to this lecture. Thank you. Thank you, one and all.